So good morning, everyone. Welcome to the lecture series for the San Diego Spine Foundation. Super happy to have Don Blaskiewicz here with us today. Don holds a very special place in my heart as one of my best friends, who I got to enter this world of spine surgery with, doing basically every case with for like 5 years. He's an amazing technician. Today he's going to talk to us about lateral corpectomy and the technique of how to do that. Don, if you wouldn't mind, just maybe share sort of your three take-home points with us, and then we'll let you get going on your talk.
Yeah. So, and I mean, I think this is so important for everybody in training, and I guess in our adult life too. Um, Really, number one is identification of structures at risk. It's risk mitigation and complication avoidance. Those are the things. I think we're so good at posterior approaches. That really is like our home turf. But as soon as we roll a patient on the side or we come from the front, there's a lot of things up there that we really aren't deputized to be damaging or fixing. So I think, the fellows coming out of the programs, they see a lot of very transformative surgeries. But to get to that point, we've all got out on that thin ice. And really, the last thing you want in your career for you, most importantly for your patients, is a major complication to vascular or pleural or visceral structure. I mean, Adam Cantor got famous in a certain way. I'll just leave it at that. And we always joke at it at meetings, right?
Yeah, that was
So
true.
we don't want that. You don't want to be that guy.
Well, thanks, Don, and look forward to the talk. Look forward to the talk, and so grateful to have you as part of our program.
So here's some disclosures. I guess maybe the relevant one is Globus Nuvasive, who we've worked with for years, friend of the family. So the objectives of this talk are understand the rationale for a lateral corpectomy, review pertinent anatomy, review lateral retropleural and retroperitoneal access, review disc access, review corpectomy technique, and then some case presentations. And as Greg had me tee up, the most important objectives are identification of structures at risk, risk mitigation, and complication avoidance. So let's jump into rationale. We know when we want to do a corpectomy from posterior, we can go transpedicular, costotransversectomy, or lateral extracavitary. From the front, we've got open thoracotomy, transdiaphragmatic. And with each of those, there's, I think, issues with access and potential complications. So you have to kind of choose it based on the pathology. So pick your approach accordingly. And then there's the endoscopic one. Never done one, never want to do one, no interest. There's a lot of guys that can. So why less invasive? So we can avoid the sharp bite, incision, and the tissue trauma, the devascularization, the approach-related nerve damage, dual lumen intubation, chest tubes, pulmonary complications, infection risk, prolonged length of stay, and longer return to normal anatomy. And those are sort of the hallmarks of why we do anything less invasively. So why XLIF corpectomy? And again, I'll use the branded version because I only use the Nuvasive Globus implants. Number one, we can accomplish the traditional surgical goals. We use conventional instruments and techniques. There's minimal patient morbidity relative to the big open procedures, and it's procedurally designed and integrated technologies with neuromonitoring access, expandable vertebral body replacement options, and lateral and posterior fixation options. And again, so this picture really says it all when you look at sort of the bigger incisions. Even though this was like a combo case with a Nuvasive retractor, you can see a lot of other stuff in there. So anatomy, this is so important. So when the trainees start to look at MRI scans, it's really not just looking at the vertebra, looking at the canal, looking at the nerves, but it's looking at the everything else that is in the way of our surgical corridor. And so this is just a walk through sort of the retroperitoneal portion of this, understanding where's the aorta, where are the segmentals, where are the iliacs, the veins, the vena cava, the bowel, and the kidneys. And these change at every level. So if you're up higher, you have an aorta and vena cava, kidneys, you can see them there. And as you get a little bit lower, things start to change. You get bifurcation into the iliac vessels. And then you get below the pole of the kidney. So that's what you have to understand. Another thing is to look for aberrant position of the vessels. So here's a lateral position of the iliac, and that's important. If you come across with a cob on that, you're very well likely to nab this as you come across the annulus, and that can create, massive bleeding, and you don't want to get into that. Also understand the difference between normal and transitional anatomy. This is usually somebody that you're going to have difficulties getting in because of just the plexus. Putting a laser plexus is more anterior when you see the psoas drawn anterior. We also have to consider rotation. So in this person with scoliotic deformity, you can see sort of this is the trajectory of the approach, and here we have a kidney in the way, and the last thing you want to do is try to be mobilizing this or not mobilize it and get into the kidney or get into the renal vessels. So again, pick your approach accordingly. Another thing that we oftentimes don't think about when we're doing lateral surgery is the blood supply to the cord. The anterior spinal artery provides 2/3 of the blood supply to the cord and basically fuels the motor tracts of the cord. And so the artery of Mundowitz, as I like to call it, comes in here, usually makes this, hairpin, and it joins in this watershed area with, the blood supply from the ASA that comes from the verts. So, the artery of Mundowitz, and I don't know why that was renamed that. I don't know. We'll have to look back in some case logs, but it typically arises from the left side of the aorta between T8 and L2. And although the artery of Mundowitz is found above T8 in about 15% of people, and has been documented having a diameter from 0.6 to 1.8 millimeters. And this is important because these are the segmentals. See these? If we're going to be coming through and we're going to have to do a corpectomy here, we want to make sure part of our approach, we're not taking out the artery of Mundowitz and giving someone a spinal cord stroke. And so this again is structure at risk, and we have to think of risk mitigation. So if I'm going to do a corpectomy, I will get an angio. It used to be a spinal angio has a 1% risk of stroke. I think it's probably even less now since their technique's better. At UCSD, they had a really good recon for a CTA with a lot of fidelity in identifying, the major radicular artery. So those are things that you could talk to your radiology team about. But anytime I'm going to be doing a corpectomy and intentionally taking one of these segmental arteries, I always get a vascular study. It's better to know it in advance than later. So let's look at this. Again, this is where, this is not our territory.
Hey, Don.
Yes, sir.
For the fellows, what are you looking for on those vascular studies that would alter your approach or alter your, the way you think about getting to the spine? What would be a result, for instance, where you're like, I need to rethink what I'm doing?
So if the radiologist said that the artery came in on the left at L2 and your fracture's at L2, I would consider going in on the right, but I would be very conscientious of the contralateral wall. So I would think that too. And if it was a major concern that I was going to, sacrifice that artery, I would just maybe change my approach. I do it all posterior just to avoid that, because you don't want to try to do something good and end up with a bad complication. I know there was a recent talk, and I forgot where I was that I saw it, but And I forgot who did it. It was a female neurosurgeon, and she was actually saying that you can actually take this artery in the vast majority of the cases, but I mean, I wouldn't risk it.
Yeah.
I
Cool.
hope that helps. But
Yeah.
it would, for me, it would basically change the approach. Okay. So you got to know your spaces. So if you're going to do a corpectomy for whatever reason, you're either going to be in the supradiaphragmatic retropleural region, or you're going to be in the transdiaphragmatic retroperitoneal space, or in the subdiaphragmatic retroperitoneal space. And I think that's what we're most comfortable with as like lateral surgeons is working in this space. But at some point you're going to have to deal with the diaphragm, even on, regular disc surgeries. So understanding, the diaphragm, and how to fix it is, I think, really important. So what is a diaphragm? It's a dome-shaped musculotendinous partition between the thoracic and abdominal cavities. The superior surface is covered with parietal pleura and pericardium, and the inferior surface is covered by the diaphragmatic fascia. And its attachments can be divided into three categories: the sternal or anterior, the costal or lateral, and the lumbar or posterior. Sternal attachments, basically it attaches everywhere. So it'll attach to, the sternum, the xiphoid, it'll come over here. And there'll be an aponeurosis with the transverse abdominis in this area here. And then as we come along the costal attachments, basically it'll attach to all these ribs in here, coming from the front and all the way up here. So anteriorly, medial 7th and 8th ribs, laterally from 9 to 10, and posterior 11th and 12th ribs, and then onto the TP. Okay, posteriorly, the diaphragm forms two arcuate ligaments. So these guys, the lateral arcuate ligament spans around the quadratus lumborum right here. And it attaches medially to the transverse process of L1 and laterally to the rib of T12. And then the medial arcuate ligament spans across the psoas muscle, attaches laterally to the process of L1 and medially to the corresponding crus. And I remember at one point you and I were doing a case together, and you're like, man, the psoas and the diaphragm almost make like a central tendon the way they come together, because like we don't really see like this when we're doing surgery. So it almost becomes indistinguishable between, the diaphragm and the upper part of the psoas. But I definitely remember you saying that. It was an observation you made. It was a Mundus oh wow moment. Okay, thoracic approach. So you can do transpleural or retropleural. I always try to do transpleural if possible. That way you're not getting into the lung itself. So the visceral pleura is the inner pleura that encapsulates the lung. And then the parietal pleura is the outer pleura attached to the chest wall. And then the pleural space is between these two planes. Okay, vascular anatomy. Similar to the lumbar cases, I will look at the aorta. I'll look at the position of the aorta. I do this on every thoracic case I do, even like a lot of the scolies I do, because that aorta sometimes is right up under the TP, and that's important to know where this is. So I'll check all that out beforehand, look for if there's, any ectatic aorta, some, aneurysm in the aorta. You want to know about this. This is a slice through T12L1, and you can see sort of how this aorta migrates around and the vena cava migrates around. And then there's all this other vascular stuff in here and sympathetics that, again, I think we need to be very cognizant of. When we get in here, wait a second, there we go. We got the azygous vein. You can see the esophagus, the splanchnic nerve, sympathetic trunks. Again, if you're going to be getting into the chest, spend a little time beforehand, pre-gaming, and thinking about, you know, all these structures that you might run into and what is the sequelae of sacrificing one of those. I think I've been pretty lucky my entire career because I've always been in institutions where we have in-house CT surgery. And it was always great, you know, to have Rob Adamson or Walter Dembitsky take a look at your pictures and say, you know, hey, do I have to worry about this? Hey, do I have to worry about that? And the other part was that they were always in the hospital should you ever need them to come into the room. So if, you know, you guys are going to be getting out into this, you know, out in peripheral hospitals and you don't have CT surgery, you know, be extra cautious because there's nothing worse than having to, you know, pack up a patient and send them to a higher level of care if you could have avoided that preemptively. The other thing we have to deal about is the neurovascular bundle. It lives under every rib. It's there. So as you're taking ribs to get into the chest cavity or retroperitoneal space, just know that they're there. Then there's consequences to taking all of these, particularly numbness and so forth. The artery will bleed. So get it before it gets you. And as we come in here, if you're doing a disc, you can sometimes come between the ribs. If you're doing a corpectomy, usually you end up having to sacrifice a rib or two. So just be, you know, prepared for that. So with the transdiaphragmatic retroperitoneal approach, I will use a 2-finger technique. I will use an index finger through the posterior lateral incision. I'll pass the dilator through the proximal diaphragmatic attachment at the chest wall and then onto the vertebral body. And probably something I do a lot more now is I will actually, when I take the rib, I'll work my finger sort of on that surface and I'll pull the lung up. So I will actually come and detach the diaphragm from the rib here and then just pull everything up. And so that way you're not even having to go through the diaphragm. And that's probably like a modified technique that I've picked up over the years. This, I think, let me see, I'm going to try to switch. Can I go to not a pointer, pen? I don't know. It's not going to let me play a video, but this is basically wanding through this space, getting down here and docking onto the disc. And so once we're down there, we're in the retroperitoneal space and we work as usual. But again, being mindful of structures at risk. There are angled instruments. Again, if you're working beneath the ribs, you can get in with these. The cant on these is about 20 degrees, so you can almost calculate that beforehand looking at images. This was, you know, just a stock image for doing a lateral. And, you know, this is kind of interesting. This is transillumination of the chest wall, and you're looking at sort of, you know, the overlying ribs. So this is probably 10. And this is where the 12 body lies and the 11 body lies. So you can see this whole thing here where I'm kind of circumscribing with a laser pointer. That's a diaphragmatic attachment. And you can actually release that and push that up, as I said earlier, my new favorite technique to do. And again, I don't think this video is going to play, but this was basically moving this rib over and then looking at where the diaphragm exists in here. It's really thin, so it's not like it's a huge thick muscle that you can see unless you're an avid cyclist who goes up Del Dios Highway every day like Greg. And then this is getting into that pleural cavity right here. So this is, you know, the dome of the diaphragm here, and that's what it looks like when you get inside. Usually there's air coming out at you though. Okay, so localization, this is important. So identify, make sure you have the right vertebra kind of marked out, box this out with your marking pen before and your fluoroscopy, and look at what rib is most overhanging this, and then plan your incision along the course of the rib in that transverse plane. There's a number of devices that you'll use, the Alexander and the Doyen. This is basically doing a subperiosteal scraping of the tissues overlying this. A lot of times I'll do this with the bovie. I also like to use that one Penfield with the spoon to scrape and reach underneath. I think the Doyen sometimes actually can rip the diaphragm. So again, I will use the spatula end of the one Penfield, and then I'll use my finger and I'll sweep it with my finger. Again, just probably a more popular technique in my hand. And then once you get the rib off, just remember these guys underneath there. And as you're coming under the rib, remember it's not just a round thing, but it's actually shaped like this. So next time you go out for barbecue, take a moment and look at that rib. So this video played earlier. How do I turn this off? Laser pointer. Oh yeah, look at this. Is it going to work? Nope, media can't play. Okay, next slide. Here we go. So retropleural approach. So use your index finger and a sponge stick. So once you're in that retropleural space, you know, you don't know what the patient's history was. Did they have some sort of pleural event at some point? Are things going to be sticky? But the goal is to try to get in there. And I think your finger is always one of the best blunt things you can get in there and sort of create that space between the visceral and parietal pleura, kind of pushing that lung forward. You can also, you know, dissect the diaphragm attachments on the inner surface of the rib in the anterior, superior, and inferior directions. The diaphragm and parietal pleura are deflected using big sweeping motions, and that's where the sponge stick. Another thing I use, I don't use like a regular like gauze sponge, but if you use one of those like Telfa type ones, so it's not like burlap and it's less likely to tear. Just another little thing. So for whatever, this is the one video that does play, and it's kind of good because you can see using the sponge stick and finger dissection to get down in here and develop this plane. Maybe we'll play it one more time. Try to identify what we're looking at. You can see the lung moving there and kind of working yourself down into this space. Okay. So at the TL junction, so in a non-lumbar plexus vertebra, when you get the initial dilator down into the retropleural space, down to the spine, get a lateral image to confirm that the dilator is approximately centered on the vertebra of interest, parallel with the disc. The AP image, you should confirm that the dilator is flush with the vertebra. So I think the point of this, in the thoracic spine, I'll dock over the mid-vertebral body and open the retractor, and then do a disc, and then the body. And the lumbar spine, I use a different technique, and we'll get to that. So this video does not play. Okay. So this is what things look like once you're in. You know, there's like this anterior arm that comes up here with this whisk that goes on here to help hold the lung out of the way. And it's really like it's a fantastic corridor. You can see everything you need to see in here, and it's really impressive, like what you're able to visualize with these retractor systems. And that's the fluoroscopic image. So this is taking the segmental artery. Again, that's sort of objective number one. Once I get out of there, is identify where this is. I'll always have hemoclips handy too, because, you know, sometimes when you cauterize a vessel of significant diameter, even though you cauterize it, the lumen remains open. And so I'll just, you know, snap a clip on here if I need to. Next step here is to do your annulotomies above and below. And one of the things that really facilitates getting your implant in is making sure you release the contralateral annulus. So, you know, when you get in there with the cob, making sure that space is open. And this is really important. I think cobbing all the way across, releasing the annulus on the contralateral side. I'm going to get the laser pointer back up here. It's so important, because if you don't do this and you don't get this cleaned up, then what's not going to happen is you're not going to be able to get the end plates of the implant across sufficiently, then your cage is going to be malpositioned and could create a lot of downstream complications for that patient. Let's see. So now when we take the vertebra, we have to think about, we have to make basically like 4 cuts. And what I'll do is the anterior portion first. If you were to do the posterior portion, then this is a free floating fragment. And so as you come across the anterior part, I will hub 1 disc space. So as you come with the chisel, and remember, these are, this has sort of like any other chisel, it has a trajectory to it. So it's angled on one side, flat on the other. And so it'll always cut towards the flat side. That's where it'll drive towards. So make sure that you're driving into the body versus driving into the chest. And so I'll make a cut through 1 disc space anteriorly, the other disc space anteriorly, connecting those dots. And then I'll go posterior and get the 2 cuts across here. And then remember, because these bodies are diamond shaped, when you cut posteriorly, you usually go to the pedicle. When you come anteriorly, you probably want to stop a little bit short, maybe just at that line of the pedicle, where on the other side, you'll go a little bit deeper. Because again, you want to avoid taking the chisel across this side. And notice I said chisel. One time I said osteotome, and Dr. Akbarnia didn't like it. I remember that. I'm scarred forever. I disappointed him. Okay, vertebral body removal. There's all sorts of, these great design, minimally invasive rongeurs. So there's these double action rongeurs so you can get down the corridor. I would say use caution with a contralateral wall because there is a segmental on the other side. So as you get through that, be prepared, again with cautery, again with a vascular clip if you need to. And then if you'd like to, you can indirectly decompress the canal via ligamentotaxis. However, if you need to directly decompress the canal, sometimes by stepping around to the front of the table or the abdominal side of the table, you can have really good visualization of the canal. And you can use curettes or what have you to pick bone fragments out of the spinal canal. Just be warned, there's a lot of epidurals in there, like we see it every other case we do, and they like to bleed. And you also need to be aware of ventral dural tears. Sometimes that bone that goes into the canal can, create a durotomy. So be prepared to deal with that if it arises. Another thing I do is I try to get my implant all sort of figured out before. I'll measure things before, but you can come in here and you can determine once your discectomy is done what footprints you're going to want. You're going to measure for the size of the core, the barrel of the core, and the height of the fully expanded core. So once you get these measurements, the device can actually be put together on the back table because this is a rate limiting step for the case. So the more information that you provide early on, the more prepared they're going to be on the back table to get this rolling. Under AP guidance, you're going to put the implant into the void, and you're not going to have it all the way collapsed. You're going to have it nearly expanded, and you're going to spin the handle to expand this once you've got it in place, and tamp, 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 gently tamp, and you can change the angle of the inserter, cranially, caudally, to kind of squeak those implants in. And I always try to make sure the central axis of the implant is in alignment with the posterior spinous processes. And then when you're cranking this up, you got to be really careful that you don't over distract, because you've created a highly unstable spine by doing this resection, and you can definitely over distract this. And if you do that, you can cause, neural injury, vascular injury. So just be cautious. Then we final tighten this guy, lock it down. There's options to do a Canada construct with a lateral plate, or, posterior, rod screw fixation. So now with the retroperitoneal approach, as I said, I do 3 separate transpsoas dilations. So I'll nab the disc above, the disc below. And it's the same way just doing a lateral surgery. I'll dilate, I'll stimulate, I'll make sure I don't have any neural structures in the way. And then the third dilation I do is I'll do the corpectomy. So I'll go mid-body, posterior, I'll dock there. I actually usually will put a K-wire in there, and then get my retractor set up. I know you guys have seen this a lot. You guys are doing a lot of lateral surgery, but just like from the outside in approach, you've got your ilioinguinal, iliohypogastric, lateral femoral cutaneous nerve. They all live within the musculature on the side. So the point is, when you're doing these lateral approaches, don't just burn through that with a bovie, do blunt dissection. So the last thing you want is somebody with a pseudo hernia of their abdominal wall.
Or their plexus.
Pardon me?
Yeah, or a thermal injury to your plexus.
Yeah, or thermal injury to your plexus, exactly. We know this anatomy pretty well. With this, a lot of times you will see the genital femoral nerve sitting on top of the psoas when you're down there working. We know that the plexus usually is 72 to 74% of the time. It's in the posterior third of the disc space at L4. Know it's there. A lot of times with these corpectomies, you actually get a good view of it because you have a wider scope. And again, you can just sweep it back, move it back with a dilator or something. We know the 2-incision technique, making that posterior incision, getting in. And I still do this. I'm still like a purist in that sense. I still will do two incisions, even for a disc. I'll get in, I'll free everything up, particularly in thin patients. A lot of times that descending colon's there, and you can kind of push it forward with your finger. If the kidney's there, if you're up higher at L2 or something, you can actually kind of sweep that anteriorly. So I still use this technique. Whatever neuromonitoring you're using, you're going to make sure that you got your twitches, and as you dilate, make sure you have a safe corridor as you rotate this around. Just mentally think what kind of signals you'd get if you were kind of in this corridor here. You'd get low values in front, low values in the back, and to you that should mentally imply you have to pull out, come anterior, and then sweep all that back. Once you get down in here, again, just making sure that you're working in the plane of the disc space, from the lateral view, making sure you're looking down, again, the pipe of the disc space, not in one direction or the other. And then just like with doing lateral surgery, I'm very efficient at this. It's annulotomy, Cobb's pituitary, maybe box cutter, pituitary, trial, end plate prep, implantation. My lateral game is really tight at this point in my career, probably done over 1,000 laterals. So I try to keep my times very, very efficient, because we know that plexus injury is directly correlated to time of retraction. So dilating here, so docking, coming in, Cobb, releasing the other side. A lot of times on these corpectomies, because they're traumatic, I'll actually end up using this because there's quite a bit of disc in the disc space. Whereas if you're doing them for deformity or a lot of other things, a lot of times right after you do the Cobb, you go to start doing paddle sizers. But there's a lot of disc, so you got to clean it out, and that's helpful. Don't forget our goal is fusions and making sure the end plate's prepped. When we're doing the trialing, we can again start to determine sort of the length of this that we're going to put in for the end plates. Case presentations. I don't know what happened. There was a little intro to each of these with a case vignette. Some of them are here, some are not. But this was like an L2 traumatic burst fracture with bone in the canal. And so with this was a perk case where I perked him first. And a lot of times if you do, the posterior part first and you perk them, or, put your instrumentation in, because they're on the table, they'll fall into anatomic position. They're what we refer to as a hot deformity. And so just by positioning on the table, you're able to correct that. And then in the second stage, I came in and did the corpectomy, and you can see how I'm taking out, one disc space and a portion of the body there. coming through and then moving up to the other end plate. And again, coming down to, the depth of the contralateral pedicle. And then when the implant's going in, gently tamping it in, again, making sure the axis is in alignment with the posterior spinous processes, end caps, planned beforehand, what angles you want, and finished product. Here we are post-op. All looks good. This was a case of spinal metastatic disease, 48-year-old female with isolated L3 met. There's a little blush above and below. So the plan was percutaneous instrumentation, L1 to L5, balloon cement augmentation of the tumor-involved segments of 2 and 4. And then part 2 was a lateral corpectomy. And then the other thing was, this is also an opportunity to fix this scoliotic deformity in here. So while I was doing the posterior part, I was able to distract and compress to sort of horizontalize these vertebra, cement augmentation above and below, moving on to the corpectomy. I mean, gosh, that body looks non-existent. And then getting the implant in there. And again, trying to make sure that, we maintain our alignment objectives. She went from 12 degrees of kyphosis into a more normative alignment. Here collapsed and there expanded, and that kind of Cobb angle corrected. Here's another case. Yes, that is the Dave & Buster's on the 8. Yes, that was a pickup truck. And this is what happens when somebody forces you off that. This young guy, military guy, had a burst fracture with a huge chunk of bone in his canal. He had a neurodeficit. So I did go in the back initially and did some decompression and tamped this down, and then came around and did the corpectomy. He also had a little, I think, defect in this end plate. So I did cement augmentation, and I think I used Prodence on that. So it's tricalcium phosphate paste. Okay, this was a fun one, and Greg remembers this guy. This was a patient that we had inherited. He had a post-infectious kyphosis. I think the first go around, we tried to use one of these little mini-me cages. And at the time, it looked like it was a really good reconstruction. But, because of these point load, they don't have like the big rectangular end plates. This guy failed soon after. And so it was an opportunity to fix this mismatch here in his alignment. And so we came in, we actually took out 2 vertebra, and this was a pretty big implant we put in here, but we're able to get his alignment back to where it needed to be. Wow, we did good work back then, didn't we? You remember this guy? I know you do. Yeah, I mean, gosh, man, like, I know, dude. This was back in the day. We were like,
we were doing door frame pull-ups.
I know. I was doing door frame pull-ups, and we were like knocking out these big old 2-level corpectomy cases. Like, we were just kids in the sandbox. Anyway, so in summary, I think always know your anatomy. Be aware of potential complications of the lung, the bowel, the kidney, the plexus, the vessels. Clean off the annulus bilaterally, so the implant will sit where you want it. Plan end plate angles to desired correction, and don't over distract, and get your angio. All right, thank you. So let me see. I'm going to switch screens. I'm going to come back to this. There we go. Everybody looks so serious. Nikita, what's up,
That's
brother?
all thinking.
I know. Look at that. What's up, guys?
I have like a technical question, maybe, and this is kind of specific. But when you're docking on the body, the vertebral body, are you just putting the shim into the vertebral body and then opening that way?
No, I usually don't. I'll put a K-wire in initially just to hold the retractor, because things go to the area of least resistance.
Right.
So I'll bang a K-wire in. Usually where you'd put that shim is where that segmental is.
Right.
So I don't want to run it through the guillotine.
Gotcha. Okay.
And if you look on the AP, you'll see the dip of the vertebral body.
Yeah.
The segmental will live somewhere in that, which is
You try to avoid
you're. It's usually where you're putting your
yeah,
your shim or whatever else. So a K wire will likely, even if you put a K wire in, it will unlikely pierce that structure.
Okay.
It will more likely bounce off of that kind of thing.
And you can dock the retractors with the K wire and then open.
Yeah.
Oh,
And then just pull the K wire out.
got it. Okay.
You saw the blades have the abilities to angle cephalocaudal. So you may have a smaller aperture opening here, but underneath it, you see a whole lot more.
Okay.
Yeah, and then for corpectomy, the arms on the retractor are longer, so it'll expand more anterior, posterior.
Okay. All right.
And like instead of you having the usual short ones,
Yeah.
long, because that the angle you can get out of the retractor is much bigger.
And to that point, when the aperture is small and then you're trying to get a large cage in there, are there difficulties like getting implant in?
Well, you're not doing this.
Yeah.
By the end of it, it's like that.
Okay.
It's just as you're getting going.
Uh-huh.
You ever do calcified discs with this technique?
Calcified discs, I have. It's a whole thing. It's definitely not going to be your first case. Yeah, I've done them this way, but you really got to understand the disc. It's got to be more lateral, and you just got to be prepared for CSF. It's tough. I mean, that's the thing with those calcified discs. A lot of times I'll still do them lateral extracavitary. I think I have good visualization, and then I avoid sort of the approach-related morbidity of going lateral. They're a little bit tougher, you know. Those are like those are definitely graduate level cases. Thoracic calcified discs. I love doing them, and I know Juan did a good paper on sort of thoracic discs, you know, but good.
Even he says it's a torture session, you know.
He's
a big surgeon, and he'll spend 6 hours doing a thoracic disc.
It totally is. And I remember when, you know, we first started doing those, like I actually went to Barrow. This is before Juan, and Curtis Dickman was there, and he was like the guru of all thoracic disc surgery, and he'd do them endoscopically. And him and I did a head-to-head lab. I think this is when Turner was still a resident pre San Diego Spine Foundation fellowship. Yeah, that was fun.
Well, thanks, Don.
All right, guys. We'll see ya.
Thanks, brother. Thanks so much.
Thank you.
All right, big love.